Hey, the light's red. That means live with TOA. The doctor is in. It's Friday. Welcome to the One City Studios. I'm Stahlman, your host. Thanks for being here. I hope, once again, that you enjoy these episodes. Please comment below if you have any interest in giving us topic suggestions. My little brain can figure it out, but I'd rather know what you want to know about. Anyway, this young man here is not so young anymore, is Keith Douglas. Dr. Douglas is one of our preeminent hand surgeons. He's everything about the paw, okay? We're going to talk a little bit about a rather challenging topic, numbness and tingling in the hand, because there's lots of things that can potentially be involved with that, so I look forward to this. Anyway, TOA, largest, oldest musculoskeletal care practice in Middle Tennessee. We serve patients from Knoxville to Columbia. Go to TOA.com. You can learn about our practice, our locations, what services we offer. If you're interested in medical information, we have a robust, constantly evolving and enlarging media center that has videos from many of our practitioners about various topics. All of our Facebook Live episodes are actually contained there. So go online. Also, you can actually get an appointment online if you want to. So go to TOA.com and we can help you with your musculoskeletal needs. Anyway, without any further delay, Keith, thanks for being here.
Hey, Greg.
I'm goofy. This is Keith Douglas. Keith, thanks for being here.
Yeah.
Again, Keith is super duper hand specialist, and we're going to talk about numbness, I guess, right?
Yeah. Okay. So I'm Keith Douglas. Thanks for watching today, guys. So I'm a hand, wrist, and elbow doctor. So I take care of basically any problem that affects the hand, wrist, or elbow. Take care of kids through adults. We're going to talk a little bit about numbness and tingling.
Okay. So what does numbness and tingling mean?
Sure.
Where does that come from?
Yeah. So there's a lot of different causes of numbness and tingling in the hand, and it's one of the most common problems that we see. And there's multiple different things, like you said, that can cause it. A lot of times I like to equate people. When you sit on your leg wrong. You fall asleep on the couch, you're watching a long movie, and you feel like your foot is asleep, pins and needles. That's kind of the sensation that I'm talking about. Now, sometimes when people have numbness and tingling, they feel like they have pain also. So sometimes they have pain, sometimes they don't have pain. But that numb, tingly, burning, pins and needles, that's the sensation that we're really talking about. And there's different reasons why you can get numbness and tingling. So a pinched nerve anywhere from your neck all the way down to your hand can typically cause these symptoms, and it can be other things. Some of probably the most common causes that we see are what's called a compression neuropathy or a pinched nerve. And the two most common causes of those are one, carpal tunnel syndrome, which we've all heard about, and that's where you get a little pinched nerve in your wrist. The second most common cause is called cubital tunnel syndrome, and that's where you get a little pinched nerve in your elbow. When people start to have these symptoms, I always ask them, one of the first things I have them do is pay attention to which fingers get numb and tingly. So that's really important information for me. A lot of times people come in, they say, I'm not sure, it's the whole hand.
No, they kind of do this.
Yeah, they
wave
do
their
this.
hand.
That's right, exactly.
Yeah.
But, in particular, does the small finger get numb? That's a really important thing, because sometimes it doesn't, you think it does. Maybe it really is the whole hand, maybe it's only the index finger and the thumb, but those are kind of important things to start with. Again, carpal tunnel syndrome, pinched nerve in the wrist. Some common findings that things people complain of are nighttime numbness and tingling. When we sleep, oftentimes we sleep with our hands bent. And when your wrist bent. When your wrist is bent, that increases the pressure in your carpal tunnel. And so that can make that numbness and tingling get worse. Also, because you're not moving at night, you get kind of increased pressure in the carpal tunnel, because as we move, it kind of pumps fluid back up our arm. So for those two reasons, nighttime numbness and tingling is a really common problem that people get. So you'll wake up in the morning. Some people, it wakes them up at night. Other people, they wake up in the morning, they feel like their hand's numb and tingly. They got to shake it. Sometimes it's painful. So one of the first things you can do is if you wake up at the night or in the morning with numbness and tingling, you go buy a wrist splint. And that keeps your hand straight when you sleep at night.
And that's something you can get over the counter at a pharmacy.
Absolutely. Yeah. CVS, Walgreens, any of those places have it. And really it just needs to keep your wrist straight to slightly back. And your fingers can be free. People ask if they need to wear it during the day. You really don't have to. I really tell people to wear it at night. If it gets super bad and you wanted to wear it during the day, you can. But if it gets that bad, you probably need to get it looked at.
Right.
Yeah. Cubital tunnel syndrome is where a different nerve called the ulnar nerve gets pinched behind the elbow. And that typically causes numbness in the small finger and in half of the ring finger. Okay? And sometimes it can cause pain kind of radiating up and down the arm. And oftentimes that gets worse when you bend your elbow. So a lot of times I see people that are side sleepers a lot that sleep like this. Or people that kind of rest, maybe type all day.
Yeah, like on their chair or in their car.
Yep.
They rest their hand on the console.
Exactly.
Or their elbow on the console.
Exactly. And so that's cubital tunnel syndrome. And typically the way we start by treating that is actually a splint that keeps your elbow straight when you sleep at night. And it doesn't have to be perfectly straight, but kind of 0 to 45 degrees. Because once you get past 90 degrees, that nerve starts to get pinched in the elbow. So those are the two most common, causes. And those are kind of ways you can start by, again, pay attention to which fingers get numb and tingly. If you notice that it's the whole hand, you can go buy a wrist splint. If you feel like it's just the small finger, you can really try to keep that elbow straight. Or there are splints that you can order online for cubital tunnel syndrome.
Yeah, people, when I was a resident, people would talk about actually just simple thing because they didn't have a bunch of over-the-counter splints, wrapping your arm in like a towel.
Yep. That
kind of keeps you from bending your elbow like this. That's a good trial
yep.
for the cubital tunnel
yeah.
thing at night. And you mentioned that pinched nerve can come anywhere up and down. So the nerves that are getting pinched down here, squeezed down here, actually start from your neck.
That's right.
And so it's actually common for people who have a pinched nerve in their neck to have symptoms of numbness and tingling down their arm. And so they can look the same.
That's right.
And it's sometimes difficult to say, is it my neck, is it my arm, or is it both? Because we often see what you guys call the double crush, which is pinched in two areas. And so that's where, if it continues, getting somebody to look at you makes a lot of sense, because they are treated in different ways.
That's right. Yeah. That's right. And these are things that the worse they get, the harder it gets to correct them. And for both of them, if it gets too bad, you can have permanent problems, permanent loss of sensation, permanent weakness. Particularly the pinched nerve at the elbow, it can be quite difficult to treat if it presents late. And actually about 50% of cubital tunnel syndrome, that are pinched nerve at the elbows, present with severe symptoms. So it is something that, if you notice, some occasional numbness and tingling, try the splints. But if this is getting worse, if it's bothering you all the time, if you feel weakness, if you're having a lot of pain, that's something that you probably want to get looked at, because it's always a sad situation when we see something that, gosh, if we'd seen you 5 years ago, we could have, really helped you, and now, not sure that it's going to get better.
Right. Okay, so good segue. So what kind of treatments do you have? You've tried the preventative things or the maintenance things like the splints, position changes. What kind of treatments are available for things? Well, let's talk about mainly carpal tunnel and cubital tunnel.
Mm-hmm. So carpal tunnel syndrome, the two other things we can do are steroid injections or surgery. And steroid injections definitely help. They help from a diagnostic standpoint to confirm that's what it is, and they also, sometimes they last for a week, sometimes they last for a year. On average, they probably last for a couple months. So it's a good option for buying some time, making sure we know what it is. We don't know that it actually changes the natural history of carpal tunnel syndrome. So, if people lived in the middle of the jungle and there were no doctors around, what happens with carpal tunnel syndrome? Well, things can wax and wane, and certainly I always tell people my crystal ball is cloudy. I can't tell them what they're going to be like in a year, but in general it tends to get worse for the majority of patients. And so then the best treatment we have for it is release of the carpal tunnel. So the carpal tunnel it's literally a tunnel that the nerve lives through, and on 2/3 of the circumference it's surrounded by bones, and on 1/3 a thick ligament. And so what we do is we open up that ligament to create more space for the nerve. And basically that's the same thing we do in the elbow. We take the pressure off that nerve. Occasionally we have to move the nerve at the elbow to the front of the arm. But the idea of both of these is that we're decreasing the pressure on the nerve. Carpal tunnel surgery is, people tend to be very happy after carpal tunnel surgery. Occasionally you have somebody who comes in and says, oh, well, I had a family member who had carpal tunnel surgery and it didn't work. Usually the situation in that is that one, they didn't have the right diagnosis, or two, it had gotten so bad that you can't make it better. People that have, standard carpal tunnel syndrome tend to do very well with surgery and are very happy. That's not to say there's not risks. Of course, there's small risks from anything, from any surgery. The way I do the surgery is endoscopically. So I make a little tiny cut. It's about a centimeter in length on your wrist, and stick a little camera up and release the ligament. And then you just have a little dressing that stays on for a couple days. You can move your fingers right away, eat dinner, comb your hair, brush your teeth right after surgery, but no heavy gripping, grasping for a couple weeks. Yeah.
Cool. And how about the cubital tunnel? What kind of treatments are available for that?
Yeah. So if the keeping it straight doesn't work, then the next option is usually surgery. And surgery for that, what we do is we make a little cut on the inside of the elbow to take the pressure off the nerve. In some people, we move the nerve to the front of the elbow. They both accomplish the same goal. There's kind of various reasons why sometimes we do one versus the other, but they both typically, take the pressure off the nerve. And for that surgery, people have kind of a big dressing that goes on from kind of their armpit down to their hand for about a week, and then we get them out and get them moving. And that's usually about a 5 to 6 week recovery. But again, you're getting better. You're typing, you're writing, doing stuff like that after about a week.
Okay. And then I've seen people in the office who've had carpal tunnel surgery, and then years and years and years later get it again. Why would somebody have recurrent carpal tunnel syndrome?
Yeah, great question. So recurrent carpal tunnel syndrome is very rare.
Yeah.
So about 1% of it's a hard thing to study, but I tell people that we think that about 1% of people have it where it comes back. Anytime somebody thinks they have we think they might have recurrent carpal tunnel, one, we got to make sure the nerve is not pinched somewhere else. So very occasionally the median nerve can be pinched at the elbow, certainly the neck. Then we have to think about other more uncommon things. Could they have an inflammatory problem like rheumatoid arthritis or lupus that's causing a lot of inflammation around the nerve? Swelling that's causing it to be compressed. Could people have some sort of neuropathy? Is it actually peripheral neuropathy? Is it some other sort of rare hereditary neuropathy? These are other things we think of.
And then the disease types of things like MS and things like
absolutely.
That come up with weird numbness and tingling. We always have to kind of keep that in the back of our head too.
Exactly, right. That's right. When we talk about neuropathies, that's exactly right. Again, those things are uncommon, but this recurrent carpal tunnel syndrome is uncommon. So we start thinking a little bit more about the zebras. When I say the zebras, that means uncommon things. And in some cases, though, occasionally, if we can't find anything else, then we will kind of go in and do a second carpal tunnel release. But again, we're talking about that's a very small segment of the people who have carpal tunnel.
Gotcha. So when you're evaluating somebody for either cubital tunnel or carpal tunnel, I'm sure there's a couple of different tests that you might do. Mm-hmm. Physical exam is kind of the mainstay, and history, understanding what bothers them when and where. But so there's two tests that I can think of that people will often consider. Mm-hmm. One is an MRI, mm-hmm. and the other is an EMG. Mm-hmm. Tell me about those tests. The MRI is, I think, more coming from the primary care world. Mm-hmm. I want to look and see. I'm not really sure that many of us do routine MRIs of the wrist and whatnot. But mm-hmm. tell me about those two tests.
Sure. So MRI is typically not very helpful for carpal tunnel syndrome. There are some rare occasions if somebody had a lot of swelling, if maybe I thought they had, or they did have rheumatoid arthritis, or they had wrist pain. So there are some unusual circumstances where we would get an MRI of the wrist, but typically that's not going to be part of the regular evaluation. The next test is a nerve test. Sometimes people call it an EMG, electrodiagnostic studies, and that is helpful with the evaluation. The reason it's helpful is, one, it confirms the diagnosis. Two, it makes sure there's nothing else going on. And three, it shows us the severity. The severity is important from a prognostic standpoint, because if somebody does have severe symptoms, it's going to be a little bit of a different conversation that we have about what I expect after surgery. The other thing is, it's nice on the off chance that somebody did have residual symptoms, which is rare, quite rare, but if they do have residual symptoms, that you have a baseline test that you can kind of refer back to. So, do all patients need nerve studies? Not all patients need nerve studies. The majority of patients in my practice get nerve studies because for those reasons I think it's helpful. But there are some patients that if they have classic symptoms, that we can forego the nerve studies.
Are there people who have carpal tunnel syndrome but have normal electrical studies?
Great question. Yes, there are.
That's been my experience.
Yeah, definitely.
A lot of people.
Yep, so on to that. We call it electrodiagnostically negative carpal tunnel syndrome, and it's a fraction of them. Nerve studies are quite good for carpal tunnel syndrome, but they're not perfect. However, for cubital tunnel syndrome, the pinched nerve at the elbow, about 30% of the people that have cubital tunnel syndrome have normal nerve studies.
That's actually a huge number, 30%.
It's a huge number, and so the history and the physical exam are even more important for that kind of patient population. And the nerve studies are still helpful. They give us information again potentially on the severity. Is there something going on in the neck? Is there something else weird going on? But again, they're not perfect, and so it's really a compilation of the history of the exam and these tests.
Yeah, that's been my experience. A lot of people will come in and their doc has gotten them an EMG or something like that, and we always have to be a little careful with that test in particular because it can't show everything. It's not perfect. It is a little dependent on the circumstance that it was done in, definitely. Temperature, humidity, things like that, and who's doing it.
Definitely.
It's a little bit of a subjective component, so very helpful tool, not necessarily a perfect tool.
Yeah, couldn't agree more. Yeah, agree with all those points.
And then I agree with you, the incidence of recurrent carpal tunnel syndrome is really rather rare. It's really a zebra. And so you have to think about other things, and one of those other things is it coming from the neck or somewhere above where the current carpal tunnel is? And that gets a little bit more challenging because things look, we see people all the time who have some arthritis in their neck, maybe some narrowing around the nerve, primarily the C6 nerve in the neck that makes up the bigger component of the median nerve, and they can have carpal tunnel symptoms, yet it's actually coming from pinch up higher. And we see a lot of people who, they've either gone down the road of carpal tunnel and they don't get better, or they've gone down the road of neck and haven't gotten better, and it's one or the other.
Exactly.
And because their caregivers have not necessarily thought about the other things. And so it can be a real challenge.
That's exactly right. And sometimes people come in who they say, I'm seeing them for one thing, and I ask most people, because it's so common, do you have any numbness or tingling in their hands? And they'll say, oh, I have numbness and tingling in my hands, but it's coming from my neck. And my next question is always, well, tell me a little bit more about that numbness and tingling, because some people have this preconceived notion that it's coming from their wrist, or it's coming from their elbow, or it's coming from their neck, when in fact, that's something that we kind of evaluate, and gosh, sometimes it's hard to tell for sure where it's coming from. But you're right, absolutely.
Well, I've always told people that if you put pressure on, a nerve is electrical wire, if you put pressure on that nerve in any location, you can essentially feel that pressure in any location along that nerve, and so it can be really challenging.
Yeah.
So I have a personal question. I'm a big cyclist. I'm a big guy, and for years I've had trouble with carpal tunnel syndrome developing when I ride. It's a very common syndrome that cyclists have. Number one solution is padding. Number 2 solution is make sure your bike is fit well so you're not leaning on your arms. But if all of those things are taken care of, do I have any other alternatives? And is surgery an appropriate treatment for that particular mechanism of I'm putting pressure on my hands on my handlebars, but every other time, sleeping and whatnot, I don't have carpal tunnel.
Yeah.
Is surgery something that people would entertain for that process?
Yeah, that's a great question. So I think you're exactly right that, the first things in that situation, when it's really just one particular thing that causes it, you definitely want to try to modify those factors as much as possible. If somebody in that situation, it's absolutely driving them crazy and it's something they love, I think it's something you keep on the table. It's certainly a possibility, but I would definitely be, much less likely to jump to surgery if the only time it's bothering you
Is when you're putting direct pressure.
Is when you're putting direct pressure.
Makes sense.
But direct pressure definitely can, for both the wrist and the elbow, and heck, any nerve in the whole body.
Right.
Direct pressure on the nerve can impact the nerve and its function.
Yeah, cool. Okay, well, hopefully I'm not going to need surgery.
Yeah.
But it's quite annoying. It's
Yeah.
quite annoying, and it's a super common problem.
Yep.
However, neck problems are also a super common problem in cervical in cyclists.
Absolutely.
I don't think mine's neck because it's all limited to my hands, but it's an interesting challenge that I get asked about a lot because everybody that I ride with knows that I'm a physician and they ask me about that. So that's what I deal with. Yeah. What else do we need to know? Anything crazy, weird, interesting about numbness and tingling in the hands at this point? I think you've covered pretty much everything. I mean, obviously. You cut your finger with a kitchen knife cutting onions, and all of a sudden one side of your finger's numb. That's a pretty easy diagnosis of a trauma to a nerve.
That's a cut nerve. That needs to be looked at.
That needs to be fixed.
Yes, that will not get better on its own.
That's right.
Yes.
Absolutely.
Yeah.
Yeah, that's a good point, actually. If you get a deep cut in your finger and you have an altered sensation in your finger, that needs to be looked at by a hand surgeon because more likely than not you've injured the nerve, and the only way to get it better is to repair it.
That's right. Yeah, and that's true for lacerations
basically
of wrist,
forearm,
anywhere.
wrist down.
Yeah, if you have a cut and you get numbness, that is not something. The vast majority of the times, it's going to get better on its own.
And you never want to wait on that because you only have a limited time to fix something like that.
That's right. It's easier to repair it sooner. And,
right.
Yeah.
Right. When we talked to Sean Brown about some other hand injuries, there were specific things. We were talking tendons that you got to get it looked at early. Otherwise, the function level will never be back the way you want it to, even if you can get it repaired.
Yeah. Yeah, that's exactly right.
Okay. Well, thanks. I appreciate it. Good topic. Great topic, actually. Very common. I'm sure 95% of you have had numbness and tingling in your hands at one point in your life. Come back. Figure out a different topic to talk about. You're great to talk to, and it's fun to have a different face here. So thank you.
Yeah.
He's really 65 years old. Look at him. No, he's not. He's not. But again, thanks, Keith. I appreciate it.
Yeah.
Go to TOA.com. Keith's one of our main hands. Where do you practice?
Yeah. So downtown Nashville.
Yep.
Mount Juliet and Cookeville.
Okay, so you're all over the place. That's awesome.
Yeah.
So go to TOA.com. You can get an appointment with Dr. Douglas or anybody else online. If you're in Cookeville, go see him. He's the man. But he's awesome, and I appreciate it. Thank you very much.
Great. Thanks, Greg.
You betcha. So that's it for today. Next week, I don't have a guest, so I'm going to figure out a topic to speak of. It'll probably be another boring spine topic for those people who find it boring, because that's all I know how to do. I may talk about something else. I'm not sure yet. I'm going to think about it this weekend. Anyway, thanks again. Get vaccinated. Please get vaccinated. I think it's time we got to. We're going to be dealing with this forever if we don't get a handle on this. Go out there, live your best life. Have a great weekend. We'll see you next week.